about management algorithms of fungal keratitis. And then the third talk was to be given by Dr. Vishal Jhanji from Pittsburgh. And his talk was on moxifloxacin resistant bacterial keratitis. But on account of his family problems, he could not make it to the meeting, and I'll be taking up this talk. Then I'll be talking about the unusual keratitis, followed by Dr. Sujata Das, who will be speaking on cross-linking for keratitis, and Dr. Tushar Agrawal, who will be speaking about therapeutic keratoplasty. So without much ado, I will like to invite Dr. Sharma to deliver her talk on microbiology diagnosis of microbial keratitis.
Thank you so much. Good morning to everybody. I think we have 6 talks, so time will not be really much for us. So let's begin with the, is it full? No. All right. Okay, the role of microbiology in corneal infections, I think we know, is to mainly make the specific diagnosis and not treat the patient without any idea what the infection is. And we try to help you with that. The etiological agents could be many, right from bacteria to fungus, acanthamoeba, and microsporidia, viruses, everything could cause. The bacteria-associated keratitis, mainly we divide into gram-positive and gram-negative, and even treatment also varies for the two conditions, and this slide just shows you the type of organisms that could be associated with bacterial keratitis. Fungal keratitis, again, either you have hyaline type of fungi or you have dermatiaceous, but the treatment what we have is natamycin, and I think you all know that now voriconazole is being added to that with quite a good effect. The other organisms, viruses, could be herpes and adenovirus, parasites we have already mentioned. So what we believe that first we take the sample and we try to look under the microscope and give the rapid diagnosis, because if you wait for culture, it's not going to be very useful for the patient immediately. So direct microscopy is the first step, followed by culture, because if number of organisms are less, they grow more in the culture and we can find them. If facilities allow us, we can look for antigens of viruses, and we can also do PCR in the form of molecular methods. I am very, very clear that we need to do the direct microscopy for every single case, which gives us an idea. And here is an example of a patient who was treated as viral keratitis for a long time and then had no history of trauma or contact lens. And when he came to us, you can see that this patient had what we saw. This color is really changing. This is gram stain, where the organisms are not stained well, poorly stained, and the same slide when stained with acid-fast stain, it shows you the red bacilli, which is suggestive of mycobacteria. And treatment is immediately decided that it should be amikacin 2.5%, and this patient responded very well to that. Several types of stains can be done, but at least we say that in secondary centers where the facilities are not much, we should have one microscope, gram stain, and potassium hydroxide examination of the cornea scraping. But in other centers, in tertiary centers, you can have different other types of stains, which are mentioned here. And the type of media that we use are also mentioned in this slide. Sample collection is very, very important. Not only corneal ulcer scraping, but you can, if the patient has been wearing contact lenses, one can think of collecting the aseptically with gloved hands, take the contact lens, and you can also give the contact lens solution which the patient was using to get some idea about contact lens case can be submitted and ask for the patient to bring that and can be given, as well as we can remove if there is an infection in the PK patient, suture can be submitted. Just take the suture with the forceps, put it on the blood agar on the surface, that's all. And the plate can be just sent to the laboratory. You can take out any foreign body and place it on the media also. Corneal buttons also need to be given so that we can correlate what was done with the corneal scraping, and if you have missed the diagnosis at that time, at least you know later what could have caused the infection. Anterior chamber exudates or fluids can also be sent to the laboratory. So how we inoculate some of these tissues, we make small pieces of that with we cut with the blade, mince it, and then put into different media. When a contact lens comes, we usually take the contact lens directly, and in this bottle there is nutrient agar molten. We put the contact lens inside that and pour it over chocolate agar. So you can see the contact lens sitting on the plate, chocolate agar with nutrient agar covering it, and it's called sandwich method of culture of contact lens. And the solutions can be spread on the chocolate agar, so we can actually enumerate the number of organisms present in the solution also. Light microscopy, everybody can do. I encourage the ophthalmologists to have a microscope in their own clinic if they have no access to microbiology laboratory, and this doesn't cost more than 50,000 rupees, and one can have an idea of the size of the eye. Sometimes I get pictures which are totally far from the expected size of the organism. So to have some idea what size we are seeing under the microscope, this shows you that the lowermost, the 1000 in the oil immersion, whatever looks like 1 millimeter in the 1000x magnification is actually the size is 1 micron. So with that you can calculate the size of what you are seeing, and just for reference, we always remember as a microbiologist and pathologist that RBC is 7 micron in size. So RBC size in the mind, which we have seen earlier in the MBBS time, and fungal filaments always more than 2 micron, bacteria are less than 2 micron, and staphylococcus is somewhere around 1 micron. Gram stain is available commercially in the market, very easily you can obtain that, and then you can learn very, very simple methods are already written on that packet itself how to do the gram stain. You can find out gram positive, gram negative. Left side you have gram positive and right side gram negative. Similarly, acid fast stain is also available in the market. One can use 20% acid for mycobacteria and 1% H2SO4 for nocardia filaments. But what is very popular and most people use is potassium hydroxide. If you have a fluorescence microscope, you can add to the same potassium hydroxide calcofluor white, and the staining is shown here is colorless kind of a staining of fungal filaments. It becomes very colorful if you have, and very, very sensitive method if you add the calcofluor white in that. You can see Acanthamoeba cis also very nicely fluorescing. When we look at GIMSA stain, we do not really recommend that everybody use GIMSA stain. But if one is interested in finding out about viruses, one can look for multinucleated giant cells in GIMSA stain. Other stains which are very nice, we already mentioned, the sensitivity is very high when it comes to fungi and when it comes to Acanthamoeba. The sensitivity is not so good when it comes to bacteria. Our fellows also find it very difficult. We ourselves find it very difficult to actually be very confident about the bacteria because they are very small, and there can be a lot of background in the slide which can interfere with your interpretation. These are some of the media we recommend. Depending on the size of the ulcer and how much sample you can get, you can decide how many media to use. Usually just blood agar or just chocolate agar also will give information about bacteria as well as fungus, because fungus also grows on this media. And we follow criteria to determine what is growing on the medium, whether it is significant or not. If large number of colonies are there on solid media, it is definitely very significant. If it grows in more than one medium, it is significant. If it matches with the smear examination, it is significant. And one can try again if is not able to determine whether it is significant. So what do we do in the laboratory? Different incubation temperatures are mentioned here for different media and different methods of incubation. This is how the growth looks. On solid media, you can see in every inoculation that you have made large number of growth. This is definitely very, very significant. Whereas in liquid media, it is just the turbidity. And when it is turbid, we just try to again subculture. So what you are seeing here is a subcultured plate. It has been taken from liquid media and it has been spread over that. So that's how we determine from the liquid media. We can do susceptibility testing by distribution method or by e-test, which are very, very common these days. Some of the slides I'm going to now show you the interpretation of smears and growth together. So here is nocardia. You can see in gram stain, you can see the acid-fast staining, 1% acid-fast. This is a clinical picture. And the colonies are very small and dry. I already talked about mycobacteria. I'll skip that. And this is a hyaline fungus. You can see both KOH and calcofluor white and in gram stain how it looks. On colonies, some of the colonies we can just looking at it, we can say it is Aspergillus flavus or it is Fusarium. Both are shown here. And in KOH, you can see the color. Demataceous fungus will show brown color. You can see the left side brown filaments are there. And the colony is also black in color. Candida is also very, very visible in all the stains that I mentioned, in calcofluor white as well as gram stain. And the colonies grow very easily on STA medium. Now here is one organism, maybe some of you have not heard about it, which we have been able to identify, and this we call as Pythium, which looks like fungus. As you can see, there are broad aseptate filaments, and this grows very, very fine, very thin growth on the blood agar, doesn't rise above the medium. And just by looking at the colony, now we have learnt that it is Pythium. And why is it important? It doesn't respond to natamycin. It needs to be treated with antibacterial antibiotics like linezolid and azithromycin, and that's why it's important to identify. Microsporidia causes keratoconjunctivitis or stromal infiltrates in the cornea. Acanthamoeba, we all know, it needs to grow on non-nutrient agar, and the center slide showing you the growth on this is from KOH, which is very, very difficult to recognize. It becomes very, very prominent in calcofluor white and gram stain. On culture, this is what is on the culture. It is on the medium, the cysts of Acanthamoeba. There are several methods of identification of organisms. How much time I have? Over, yeah. Okay, so I'll go fast with these are the biochemical tests. You need not know actually the details, but what is important to know is automated methods are now available for identification. You can send anywhere in a Delhi city or other cities also. Now Vitec and all are very, very common now. We look at the morphology of fungi for identification, and we also do what is called sequencing after PCR. PCR is an important method, but not so much for keratitis, because the sample is from outside. There are chances of getting contaminants in that and getting false positives. So we don't so much believe on PCR for keratitis, but it's very important for endophthalmitis. And by PCR, actually, you can detect after sequencing many new types of, that's the job we do in tertiary centers, various new types of organisms we are able to identify, which are normally not possible to identify. When we come to viruses, apart from IFA, which is for direct antigen detection, PCR is very useful, because culture is very, very difficult for viruses, and we don't do that. PCR is what we do. There are many modifications of PCR, including conventional method as well as real-time PCR, where you can detect much more of sensitivity is high, as well as it will give you the load of virus that is present in the sample. And sequencing is now done by several commercial companies. Very easily it can be done. Once the DNA is extracted, you can send that to a company and it can get done. This is my last slide with some tips that you have to take the sample from the site of lesion, that is a corneal ulcer, and direct processing. We have a technician who goes to the clinic, and we put the samples on the slides as well as on media in the clinic, so that directly it is done. and some knowledge of the organisms you yourself should have, so that you can make sure that things are done properly in the microbiology laboratory. And prolonged incubation is very important. Within 48 hours, which is the guideline for the microbiologists in general, the organisms in ophthalmology, they do not grow within 48 hours, they take time. So we need to have at least 1 to 2 weeks of, 1 week is a minimum of incubation.